Hi everyone, good afternoon, and welcome to Part 2, Academic Progression and Pathways to the BSN. This is the second webinar in the Future of Nursing webinar series, co-hosted by the Pennsylvania Action Coalition and the Pennsylvania Organization of Nurse Leaders. My name is Jenny Horn. I am the manager of the Pennsylvania Action Coalition, and I will be moderating the presentation. Before we begin our presentation, we have a few announcements. All participants will be muted during the presentation. If you are experiencing dragging speech, this could be due to your internet connection. Similarly, if you are checking email or navigating the internet, you may experience this as well. Please close any online programs to help fix this problem. If you are having any difficulty during the webinar, you may use the chat box on your control panel to communicate with the organizer. Participants should adjust their own volume on either their speakers and/or headset. Questions will be answered live at the end of the session, and attendees can ask questions by typing a question into the question box, which is located on the control panel. You can do this during the session, and the questions will be sent to the presenter to answer at the completion of the webinar. Shortly after the conclusion, attendees will be provided with a short survey to complete to receive continuing education credit. Please take a few moments to provide us with your feedback to help us improve future webinars. As a reminder, we are recording this webinar, and the link along with the PowerPoint presentation will be placed on the PONO website under the Members Only section. I'll now go over a few notes regarding continuing education credits. In order to receive full contact hour credit for the CNE activity, you must be registered, attend the entire webinar, and complete an online evaluation, which will include your name, address, and email. A conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial company with which she or he has had a financial relationship. The planners and presenters of the CNE activity have disclosed no relevant financial relationships with any commercial companies pertaining to this activity. The Southeastern Pennsylvania Organization of Nurse Leaders is an approved provider of continuing education by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Now, I'm pleased to announce the timeline of our presentation today. First, we will hear an introduction presented by Helen Burns. We will then learn about concrete strategies for working towards the BSN from Diane Hupp. Next, we'll learn about Debbie Ron's Creative Dual Enrollment Program, and then we will hear perspectives on academic progression presented by Angelo Venditti. After our presenters have completed their presentations, we'll have a live Q&A session from the audience. As stated earlier, please hold your questions until this time, and please submit your questions through the chat box so that we can field them smoothly. Once again, thank you all for joining us, and I am pleased to turn the presentation over now to Helen Burns.
Hello, everyone. This is Helen. I'm Senior Vice President and Chief Nursing Officer at Excella Health. And I am excited for the opportunity to participate in today's webinar and have you here to join us. Next slide, please. The education of nurses is a top priority for the profession. It is also arguably probably one of the most emotion-focused issues facing nursing and has been so for decades. Next slide. A report from the Institute of Medicine, published in 2011 and entitled The Future of Nursing, Leading Change, Advancing Health, calls on nurses to take a greater role in America's increasingly complex healthcare system and acknowledges the need for nurses to take a leadership role in all settings. The Future of Nursing report is most simply an action plan for the future of nursing and sets forth a set of recommendations. Next slide. One of which recommends that the proportion of nurses with a baccalaureate degree be increased to 80% by the year 2020. Nursing is unique among the healthcare professions in the United States in that there are multiple educational pathways leading to an entry-level license to practice. The qualifications and level of education required for entry into the nursing profession have been widely debated. by nurses, nursing organizations, academics, and a host of other stakeholders for more than 40 years. BSN education, relative to other educational pathways, introduces nurses to a wider range of competencies in areas such as health policy and healthcare financing, community and public health, leadership, quality improvement, and systems thinking. Care within hospitals continues to grow more complex, with nurses having to make critical decisions associated with care for sicker, more frail patients while using more sophisticated life-saving technology and with information management systems that require skills in clinical reasoning. In addition, care is increasingly moving outside the hospital and becoming more complex as well. Nurses are being called on to coordinate care among a variety of clinicians and community agencies to help patients manage chronic illnesses and prevent disease progression and complications. A more educated nursing workforce will be better able to meet these demands, and this need could be met by increasing the percentage of nurses with a BSN. An increase in the proportion of nurses with a BSN would also create a workforce to achieve higher levels of education at the master's and doctoral levels required for nurses to serve as primary care providers, nurse researchers, and nurse faculty, positions currently in great demand across the profession and within the healthcare system. Next slide. How this gets achieved? There are multiple strategies that have been put in place, such as tuition reimbursement, scholarships, loan forgiveness, increase in higher ed faculty, and the expansion of political partnerships across educational programs working in partnership with practice environments. Next slide. One final thought that this report also calls out is that nurses at all levels should continue to engage in lifelong learning. So achieving the targets requires political will and orchestrated action. I would say most simply, it takes strategy. And for that discussion, I will now be passing the presentation over to Diane Hupp.
Thank you, Helen. Good afternoon. And I too am pleased to be here today to present to you some of the strategies and tactics that we have worked on and have resulted in some success in increasing our BSN rate. I am the Chief Nursing Officer and Vice President at Children's Hospital here in Pittsburgh. So to begin with, I hope after the session today that I'm able to leave you with some very concrete, easily able to be implemented tactics that you can take back to your organizations. There are a host of different strategies that we have used to increase our BSN over the last decade. I have about 8 of them on the slides, beginning with CNO setting a vision. In addition, I will speak about the nurse leadership accountability, some of the different recruiting practices that we have used here. But the one thing that I won't be speaking of, or that you don't see on the slide, and I won't read each of those to you because I'll be going through them, is that of a waiver or an actual written commitment from the new hire. We have not instituted that here within our hospital or our health system, but I do believe there are other strategies that can help with success. So the first one I'll speak to is the Chief Nursing Officer's role in truly setting a strategic plan and setting a vision that includes the increase of individuals obtaining their BSN. When you think about setting a vision, it is more than, it's a dream, and more than that. So to say that we will reach 80% or 90% sounds like a good vision, but there needs to be a great plan behind any vision and any strategy. When I first started at Children's in the role, and that's been over a decade ago as the Chief Nursing Officer, it was something that was front and foremost in my mind, as well as in my leader's mind. It was a real expectation that setting the BSN strategic goal, but we would get to 80%. In fact, we would exceed that and have an internal goal of getting to 90%. Part of the strategic plan I've listed here, we've been through 3 different plans, and each one there's a very specific, well-articulated statement that addresses a tactic and, frankly, a goal that we would work towards achieving. Most recently, we just completed a 5-year strategic plan, and as you can see from 2018 to 2023, in which that strategic plan will run, we do hope to, and I think to get to 90% BSN. So again, the first step is really committing yourself to a goal that you believe is achievable. The next thought that I wanted to speak to you about is actually how did we ever get to saying by this year we could reach 80% and by 2020 we could reach 90%. It sounds nice, but I do think there is some mathematical calculations that it's important for a chief nurse to implement and to work through. And I have to give credit to Deb Zimmerman from Virginia Commonwealth, who several years ago performed a presentation at a Magnus conference and actually gave us a calculation, a table that we could use. It's in an Excel spreadsheet that once you put in current baseline status of your degree nurses, your diploma nurses, what your turnover is, how many you hire each year approximately, and how many you lose, that based on your current rate of hiring and turnover, it would project out 10 years as to where you would be projected to be in terms of an overall percentage of BSN nurses. So when we did this, if we just kept doing exactly what we were doing in terms of recruiting, we would not have reached 80%. So that would be a second step to say, set a goal, but is it a realistic goal? And I think that Zimmerman's projection table and calculation really can bring reality into the goal that you end up setting. So after we did that, it was a clear exercise of saying we needed to add some other strategies. So the next one I'll talk about has to do with nursing leadership accountability. So not only holding yourself as the chief nurse accountable, but every nurse leader that had responsibility for hiring and recruiting and retaining nurses, that I would put into their goal and integrate on an annual basis an individual goal for that unit director, as well as senior nurse leader. So if they currently began at a 50%, what would be realistic in the next fiscal year to achieve? And each of those had actually different targets based on their current baseline of where they were at. Because I'll show you in a few slides, we clearly have gone from a low of in the 50s to over 80%, but different units are at different actuals in this point in time, and they clearly started out in different places. So when we talked about UDs having goals and targets, we also said, well, how are we going to help them recruit and retain and get to that target? We implemented what I call is a chief nursing officer-led recruiting practice. And no, that doesn't mean that myself as a chief nurse is going to interview and recruit and hire every candidate that comes in. We have hundreds of new nurses come into Children's Hospital each year. But what that did mean was that we would look to hire primarily BSN nurses. But if you wanted to hire a non-BSN nurse and you felt that the non-BSN nurse was the most appropriate candidate, you would have discussion and approval with the chief nursing officer, myself. We would talk about things such as, are they enrolled in a BSN program? Are they considering? If they're not enrolled, maybe this candidate has been a prior candidate at the Children's Hospital and we really want to keep them. So we need to have further discussion on our expectation that by 2020, we anticipate 90% to have BSN. So how are you going to get on board? I think there was a lot of discussion between candidates and unit directors that led the unit directors to be able to sort out who really was on board with this philosophy and this that having a BSN is the right thing to do. Next, we talked about role modeling. I do think it's very important that leaders, we're all role modeling what we're asking our staff to do. So if we're asking our staff to go back and get their BSN, And if they're a new hire coming in to get their BSN, then certainly every leader would not only have a BSN, but every nursing leader at a unit director level, nurse manager level, and above would have a minimum of a master's degree in nursing or a health-related field, as well as certification. So again, we're expecting staff to have degrees and certifications here at the hospital. We have to demonstrate that we're on board with that, not just by communicating, but by doing. So it did take about 3 years, but at this point, and it's been a couple years, we've actually have every nurse manager, unit director, and other nurse leaders holding a master's degree, as well as a national certification. Next, I will talk about our local School of Nursing affiliations. I think an important strategy as you work on BSNs is certainly having open communications and dialogues and connecting with not only the BSN universities, but also the various diploma schools of nursing and associate degrees of nursing schools. We actually see over 1,600 and help to support 1,600 nursing students that rotate through in a given annual year. There are 25 plus, now close to 30 CHP nurses that serve as faculty. Why I think that's important is these are individuals that can carry and communicate our important message back to the schools in which they're working on. And nursing students are here and they feel like, wow, pediatrics may be for me, this hospital may be for me. They get to understand what the expectation would be when they come on board, whether or not they had their degree or were in a baccalaureate program at the time of their student rotation. But those discussions are also helpful to have. Of course, there comes some financial barriers. And I think as leaders, we have to say to ourselves, what can we do to help staff feel as if there is some financial support there? Because clearly for some, they have the desire, they have the interest, but it is a financial burden for them. And they can't prioritize going back to school as the #1 priority to use with their compensation. So we have worked on tuition reimbursement. We've worked as a system to elevate our annual tuition reimbursement for new hires coming on board. Over the years, we've seen that go up from a couple thousand up to $6,000 a year to help with tuition reimbursement for full-time staff. As Helen mentioned, we do offer scholarships, and each and every year I try to add one more scholarship of $1,000. And yes, it's $1,000, but every $1,000 I try to say to the student or the candidate here will help you to get that degree. We have looked at some cohorts with universities which do enable us to receive tuition discounts for these students. We also have worked hard within our health system to elevate the salary differential for BSN nurses. So if you're a BSN nurse coming in, right now you'd have a full-time nurse would have $1.75 an hour increase in their salary as a differential. And I think it is important if we're saying we want you to go back and do this, how we're compensating them. In addition, we've been able to work with human resource to actually demonstrate in a one-page format of what is the actual return on investment over a career for a nurse that goes back to school for a baccalaureate degree. And we can actually add up the dollars and be able to share that with a nurse. And I think that's been beneficial. Moving on, talking about the actual call to action. Talk a lot about why it's important amongst leaders, and we hear about it all the time, and we as leaders probably read more literature than frontline staff nurse, but I think if we're really going to expect that everyone is on board and understands the call to action, we do have to educate. I remember the very first time, it's been a decade, when I brought this topic up at a strategic planning, there was tons of discussion. So I immediately said, I have to bring back and educate. Some people weren't even as familiar with the IOM report. Nowadays they are, but I wouldn't say every frontline nurse even is abreast. So that needs communicated, and truly it gets back to the why. We all know if we want a change to happen, probably the most important thing we should do is communicate the why. Just to share with you a few of the results and how some of these strategies and tactics have helped us increase. This slide shows since FY09, and you can see we're at about a 60%, and we have elevated this year, fiscal year, up to 82%. Again, with a target, very attainable goal in my mind by 2020 to reach a 90% or very close to it. When you look at have we seen specific variances in other departments, we have. If you look at across the board on the next slide, you will see that clearly we have departments that are in the 50s, closer to 60, which is where some areas started way back in 2008, 2009. But as you can see on the left side of the graph, clearly some have attained that goal and exceeded the 90% goal. And each and every year, if I put this slide up, it would show you the incremental increases in each department. For those departments that have not hit an 80%, I have them do a specific action plan, and I actually have them redo the Zimmerman calculation, use the calculation tool to try to say, based on the strategies and tactics they're using, is it feasible they're going to get to a minimum of 80? And then finally, has this done anything for quality and outcomes? We are looking at that, but one that I can show you and share with you is mortality. Clearly, Linda Aiken's research and evidence that's been disseminated widely and studies that she has replicated time and time again show a decrease in mortality. And clearly, if you look at mortality at the Children's Hospital, from where we started, when we really said in 2008, this is a goal of ours, and when you can see an incremental increase in BSN nurses, you will see the correlation of a decrease, overall, a decrease in mortality, with a potential blip here and there depending on the quarter, and certainly depending on our risk-adjusted patients. So in summary, I would just say clearly setting a vision with really specific goals and targets with tactics that would work for you and how you as the chief nurse will really communicate and carry that message while getting in buy-in and also continuous monitoring. We have a dashboard that we clearly look at every quarter to say, are you where you need to be and are you going to meet your goal? So with that, I will take questions at the end of the presentation. And at this time, I'll be passing the presentation over to Debbie Wren.
Thank you very much. I am Debbie Wren. I am the director of the Reading Hospital School of Health Sciences, located in Reading, Pennsylvania, and as such, I do represent a hospital-based diploma program. I do want to thank you for the invitation to participate in this webinar, and I really look forward to speaking to you today about the important role of academic progression as a pathway to the BSN and increasing the percent of BSN-prepared nurses in the Commonwealth of Pennsylvania. The objectives and overview of this presentation include several key points. Today's presentation will focus primarily on a dual enrollment model of academic progression to the BSN degree. We will be discussing the component of effective academic partnerships and the benefits and barriers for seamless academic progression, and most importantly, the added value and benefits of the dual enrollment model as compared to the older and more common articulation model of academic progression. Our goal is the same, to reach an 80% baccalaureate degree workforce by the year 2020. The overarching purpose of dual enrollment academic progression is to meet that goal. Dual enrollment is a methodology of providing a seamless academic transition to the BSN degree. We know from our experience and evidence that the articulation model of academic progression, while it's better than no model at all, is not effective and has not been effective in achieving the goal of 80% baccalaureate degree workforce. Research has demonstrated that the percentage of nurses who continue their education and pursue higher degrees is very low with the articulation model. We had some research performed in Pennsylvania as part of PCAIN, an organization that has been looking at academic progression, and that was published by Rhonda Manivel and Marilyn Teeter in 2010. 2010. If we look at our workforce for the entire state of Pennsylvania currently, we believe that there's approximately a 40% workforce of baccalaureate prepared nurses. That information was last published in 2017, but it represents data from 2014. And as I'll show you in a moment, the Pennsylvania graduate data from 2017 demonstrates that currently 55% of new registered nurse graduates are entering the Pennsylvania workforce with a bachelor's degree. Therefore, if you think about the estimated 40% workforce and 55% new graduate data, the reality exists that in order for us to achieve the goal of an 80% workforce in Pennsylvania having a baccalaureate degree, we need to focus on academic progression. The next slide is going to show you a map of Pennsylvania that represents the academic landscape in nursing in our Commonwealth. There are currently 41 baccalaureate programs, 25 associate degree programs, and 16 hospital-based diploma programs. And this data was retrieved from the Pennsylvania State Board of Nursing website just within the past few weeks. Also of interest in looking at the map is the concentration of the programs. You can see quickly when looking at the map that the location of the bachelor's degree programs, which are represented on this map as blue squares, is heavily concentrated in the eastern, especially the southeastern Philadelphia area and the western Pittsburgh areas, with many areas of the state void of on-site generic baccalaureate degree programs. The other RN programs on the map are the associate degree programs, which are represented by the orange diamonds, as well as the diploma programs represented by the green stars. And then also the PN programs are on this map with pink circles. So I want to take a brief moment to talk to you about the current NCLEX data in Pennsylvania, which represents new graduate data. And this information has been extracted from the National Council State Boards of Nursing NCLEX RN report number 6. If you look at this first graph, it compares national data to Pennsylvania data for nursing graduates who took the NCLEX RN examination during a one-year period from October 2016 through September 2017, which is the time frame for annual reporting of NCLEX data in Pennsylvania. The term delivered exam simply means that we're looking at total test takers. It doesn't reflect who passed the exam and who failed. It simply is looking at who took the test. And I look at this information and because it represents the total number of graduates from RN programs, and most test takers will eventually pass the exam, although albeit not necessarily on first attempt. So if you look at the national data on the left graph, you can see that all RN graduates in the United States, of those graduates, 48% or less than half were from baccalaureate programs, while the majority of graduates were from associate degree programs, 51%, and the remaining 1% from diploma programs. Comparatively, if you look at the Pennsylvania bar graph on the right, that demonstrates that 55% of all test takers were from baccalaureate programs, which is 7% higher than national data. 33% and 12% were from associate degree and diploma programs, respectively. So if you do some comparison between the national and Pennsylvania data, you will see that the percent of BSNs entering the workforce is greater in Pennsylvania as compared to the national data, and the combination of associate degree and diploma graduates, which adds up to 45%, is less than the combined national data of 52%. The next slide represents almost the same information, although we're only looking at past exams. So we're looking at those individuals who passed the exam on first attempt. And I include this information only for those of you who may be wondering if the data are significantly different, and that it really is a very similar looking graph compared to the one that we just previously looked at. So I think we can skip to the next slide. This then is an information in graph form that shows the same Pennsylvania data, but in longitudinal view. So as you can see, the percent of delivered NCLEX RN exams, that being total test takers or total graduates, for BSN graduates, which is the blue line, has increased from 46% in 2013 to the current rate in 2017 of 55%. I'd also note that if we go back in time a bit further and we look at the National Council State Board of Nursing report in 2008, which is 10 years ago, only 43% of the RN graduates were from the baccalaureate programs. So according to this NCLEX data, in a 10-year time span, in Pennsylvania, we moved the dial of baccalaureate graduates from 43% in 2008 to 55% in 2017. And this slide that we're on currently looks at the same data, only it's looking at those who passed on their first attempt. When you look at these graphs, you can also see the declining percentage of associate degree graduates and diploma graduates throughout this time span. So if we start talking about the academic models, currently most schools use the model of articulation. But it's been noted that the traditional articulation model is relatively ineffective in increasing the BSN workforce. And thus, Robert Wood Johnson Foundation and the Center to Champion Nursing has highlighted several other academic models that are alternatives to articulation. And these models are represented by the bulleted points on this slide. They include competency-based curriculum, which is competency where the schools represent different competencies and look at competencies that should be taught in the baccalaureate program versus competencies taught in the associate degree or diploma programs. Shared or statewide regional curriculums, where a state or a region all share the same curriculum, which helps with academic progression. Community colleges being able to grant the baccalaureate degree as part of the community college. Accelerated RN to MSN programs or BSN to DMP programs, the dual enrollment model, and then the newest model, which is where an associate degree or diploma program is actually embedded within a bachelor's degree program with no stop out for the associate degree or diploma program. As a hospital-based diploma program, for us, the dual enrollment model best suited our needs. So this articulation model, which is the old model, is still used by many programs in our Commonwealth. And the simple graphic that I designed demonstrates that this model represents two independent programs who contractually agree to articulate together. So the diploma program has a 2 to 3 year independent diploma program, and the university has an RN to BSN program, and the articulation or contract that they work together to design a program where the graduates can move from one program to the next. In this type of model, curriculum planning is not required. Each program can operate separately. Academic progression is encouraged, but it's a separate educational experience, often requiring additional application to the college or university, meeting new admission criteria, sometimes repeating of already taken courses. And the awarding of credit for prior education and experience is determined solely by the college or university, and that varies from program to program. Following graduation, the diploma or ADN graduate can complete a program at a number of colleges or universities because the programs will have multiple affiliation agreements. In the new model, which is a dual enrollment model, this graphic will show you that it's meant to represent the collaborative nature of dual enrollment, whereby a student is enrolled simultaneously from day one in two different programs. For us at Reading Hospital School of Health Sciences, we have a contractual agreement with Alvernia University. Each of our two programs still maintains its own independence, but we are married together by a dual enrollment process. Our curriculum was planned together. From day one, we worked together to share ideas about the courses and plan the curriculum all the way through the RN to BSN completion. For every course in our programs, both general education taught by AU and nursing courses taught by the Reading Hospital School of Health Sciences, the students receive credit, and those courses are transcribed in both the diploma program and the college. So at the end of the 3 years where the student is in our program, they've earned 89 credits at our program, Reading Hospital School of Health Sciences, and they've also earned 89 credits that are transcripted at Alvernia University, which allows them then to receive a diploma in nursing and sit for the NCLEX RN, as well as an earned associate degree in science from Alvernia University. But most importantly, because we planned the entire 4-year program together, the graduate could seamlessly transition directly into the AU RN to BSN program. They've already earned those 89 credits for years 1, 2, and 3, and they only need to complete the final 4th year to earn their bachelor's degree. This dual enrollment model allows a student to complete their bachelor's degree in 4 years of full-time study, 9 semesters, 123 credits, which is the same requirement as the generic BSN at Alvernia, while still allowing the student to enroll in a hospital-based program. Details of this type of model can be adapted to fit other programs. It can be adapted to fit associate degree models as well for dual enrollment. Again, the next slide shows you just some of the overviews of the model and what the responsibilities are for the diploma program and the responsibilities for the college and university. For the diploma program, it's important to note that we are independently owned and operated by the hospital, and that the first year of our curriculum, which I will show you in a moment, there are embedded general education courses that are taught by the college or university on our campus. We are accredited by ASIN for the diploma program of years 1, 2, and 3. We are responsible for the NCLEX pass rates. We award the RN diploma at the end of year 3, when at the same time they will earn their associate degree in science from Alvernia University. The college or university then, all courses in the year 1, 2, and 3 earn college credit. Our faculty are provided affiliate faculty standing at the institution. They are not paid by Alvernia University. We pay the faculty at the hospital. And Alvernia University will then independently award the BSN at the completion of year 4. They carry their own separate accreditation of choice for their institution and the RN to BSN completion portion of the curriculum, and they do as well also have a generic program. So there's a lot of considerations when you want to set up this type of a model. The dual enrollment is very complex because you have to be able to coordinate all sorts of things such as recruitment, admissions, policies, and all of the other areas that I've noted on this slide. We'll talk about a few of them, but keeping track of time, we will not go into all of these areas. I will just mention with curriculum on the next slide that we created that curriculum together, and we talked already about the transcription of courses at both institutions. I think we've covered this slide relatively completely. This is a model. I think we just skipped one. There is a model of the actual curriculum, which I won't spend a lot of time talking about. I think you can just look at that, and we can talk about that later during the question and answer period. As far as recruitment and marketing, again, this is an area that we needed to collaborate. We market and recruit the programs from the very beginning as both Reading Hospital and Alvernia University programs. As far as the admission process, we work together with the admission offices from both of our organizations, and we work collaboratively. We looked at our admission criteria and agreed upon admission criteria so that the students who are admitted to the diploma program are automatically enrolled in the college and university and meeting their admission criteria as well. We share documents between the two organizations, and we have a collaborative agreement regarding transfer of credits. As far as faculty, the faculty in our School of Nursing at Reading Hospital are all 100% either MSN or doctoral prepared faculty. We meet the state board requirements, and we are, as I said, given an unpaid affiliate faculty standing at the university. We share grades between the two universities and transcript the grades on both of our transcripts so that students actually have transcripts with us as well as with Alvernia University. And we try to mirror as many possible policies and procedures as possible between the organizations. We do both have criteria that we need to establish based on the agencies that we both report to. We provide student orientation together Financial aid is the responsibility of the diploma program for years 1, 2, and 3. And then year 4 would be at the university, and pay their tuition to us as well. There's a lot of financial implications that are crucial to the partnership, and a lot of those issues relate to, for the hospital, Medicare pass-through requirements that we need to meet in order to satisfy Medicare regulations, and those are listed on this slide. So in conclusion, I would declare that this is not a win-win situation. Dual enrollment and the process that we are engaged in with Alvernia University is a win-win-win-win-win situation for the diploma program, the college and university, our students, the hospital, Pennsylvania in improving the workforce, as well as our profession and patients and clients. I really do appreciate your giving me the opportunity to talk about dual enrollment, and I'm looking forward to your questions. I will now be passing the presentation over to Angelo Venditti.
Thank you so much. I appreciate the opportunity to speak here. I would like to thank Ponal and the Action Coalition for putting this together. This is great content. Next slide, please. I think it's important to frame the conversation around why we're interested in having our nurses pursue BSN and why this is important. And some of this was highlighted by previous presenters, so I'll move fairly quickly here. But when you look at our professional organization, the ANA, you will see that there is a commitment to lifelong learning expected out of us as professionals. And specifically what I highlighted here is the need for culture change in really influencing our staff and practitioners to become interested in lifelong learning. And that starts with a commitment to BSN. We've highlighted some of the quality aspects and that the benefits it's had on mortality, but there also is subsequent literature that talks about the benefit to congestive heart failure, mortality, decubitus ulcers, failure to rescue, deep vein thrombosis, pulmonary embolism, and length of stay. So there is a comprehensive quality benefit as well as a personal benefit to our staff as they look to pursue their BSN degree. Next slide. Bridging on to that, the level from our professional organizations, our philosophy has been both strategic and cultural. And so as many of you have heard the saying that culture eats strategy for lunch. And we have taken that very seriously in our culture. And so beginning with our system CNO, Sue Roble, who really sets the tone for lifelong learning and lives as an example of that, all the way down to our staff, setting the tone upon entry into the organization and orientation, that we hope that our nurses have a commitment to lifelong learning and progression. In terms of our strategic approach, we have supported the need for lifelong learning and focused our strategies really on the barriers that nurses often encounter. These are well documented in the literature and are complemented through our conversations with our staff. So for our nurses returning for BSN, we really focus on offering flexible schedules so that they're able to commit professionally to their job. They're able to commit to balancing home life, and they're able to commit to the program they enter. We've made some increases in investments into tuition assistance and other scholarship programs. We have leveraged our partnership with many organizations to offer discounts, which we feel is a creative way that is a win-win for the partner organization and for the institution and our nursing staff. We have recently created a nursing institute, which has provided a great focus on learning for our nursing staff, and really, as part of that institute, focused on the progression of education. As we're focusing on BSN, it's important to highlight some of the other benefits, such as certification is no cost. And sometimes staff use this as a means to dip their toe in the water and see if they can handle a BSN program. And so they'll pursue certification as a confidence booster to enter into formal education programs. What I think is necessary to highlight, and probably one of the most important aspects of our strategy, is the mentorship and coaching throughout education programs. And so when we have staff who are entered or leaders who are entered in a BSN program, we really provide them with access to folks who have done it successfully, and really coaching to be able to balance the work and life demands that come as you're entered into a program. Next slide. It's important to highlight the importance of partnerships and how those partnerships are structured to meet the needs of the individual learner. So you will see, not that I would endorse any one program on this slide over the other, but what I would say on this slide is that there is a learning delivery for just about any preference you could think of. We have a partnership for hybrid programs. We have a partnership for online programs. We have a partnership for RN to MSN, so on and so forth. And so we help to partner with programs that allows us to individualize the needs of our learners. And that is why we have partnered with so many organizations. We are in the process of partnering with a 4-year ASN BSN program, which our previous speaker talked about, and anticipate that program to start in the very near future. So the other thing that I think is highlighted by these partnerships is the investment into lifelong learning. And you can see that many of our partnerships not only focus on BSN, but the MSN and the DNP, both online and on-campus programs. So there really is an offering for any learner, and they're really able to individualize their approach. Next slide, please. You can see that we've accomplished nice progression into our BSN nurses, and so we've seen increases year over year, and we're very proud of that. Next slide. You can see that segmented by region, that we continue to see progressions in all of our regions, and it is by virtue of the vast partnerships that we have, the culture that Sue's leadership has provided and other leaders in the organization, and that we have really been successful modeling a strategy that removes barriers for our nurses to be able to pursue. Next slide, please. So with that, I would like to just open it up and ask if there are any nurses that have joined that would like to share their story. And I have someone here who raised their hand. I'll turn it over to Raphael, who is one of our ICU nurses in Wilkes-Barre, to share her story.
Hi, so my name is Raphael Farrow. I work in the ICU at GWB. I worked there for 4 years, and prior to that I worked on like a med-surg tele trauma floor. I, fortunately, have been lucky enough to just finish my BSN as of last Thursday through a local program here. So I didn't envision when I became a brand new nurse 12 years ago that I would be encouraged to reach my fullest potential and obtain my BSN. The Geisinger culture supports my professional growth. Obtaining my BSN was made possible by the support I received, and that support I received meant that the Geisinger leadership team supported me in reaching my future goals. Geisinger showed commitment to my professional development, both monetarily. I was lucky enough to receive tuition reimbursement, and I was also lucky enough to receive a scholarship. And also I was able to obtain, go to school through a cohort program through a local university that the hospital partnered up with. The Geisinger leadership team made obtaining my BSN accessible by holding classes here on campus. I was ensured classroom availability on campus here at the hospital to hold classes. Obtaining my BSN was also achievable by having support and attending classes with my peers that I work with on a daily basis. The leadership team in the ICU supported me as well by empowering me to have a say with my schedule. I was able to do self-scheduling so that I was able to only work 8 hours on the days that I had classes here on campus. My future goals include continuing my education and obtaining my MSN.
Thank you, Raphael.
You're welcome.
So just to summarize quickly, I would point out a few things. Culture really drives the environment and the wish for our nurses to pursue lifelong learning. We believe that strategy should be focused on removing barriers that exist for our nurses, and that the programs we're able to offer in partnership with other organizations are really geared toward the individualized needs of our nursing staff, so that we're able to offer a broad scope of programs and delivery mechanisms, and they are able to gear learning to their style. And mentorship and coaching through the learning process is important so that they are able to handle the balance of work, home, and the program itself. With that, I'll turn it over to Jen, and thank you again for the opportunity to talk today.
Great. Thank you, Angelo, and to all of our presenters. So we'll now open it up for the remaining time in the hour for any other stories that you would like to share about your academic progression story, or any questions that you might have for any of the presenters.
Jenny, there's a question in the chat box pertaining to dual enrollment. The question is, since it is dual enrollment, 2 programs, a partnership, can you call it a program?
Hi, this is Debbie. I'm not sure if I fully understand the question, but I will try to respond to that. We are dual enrollment programs, so there are 2 programs, and we are independently operating programs. We are not in any kind of relationship where we are working, under one roof or under one umbrella. So we are independent programs operating together, and we have agreed to engage in the dual enrollment model of providing the 2 programs. So I'm not quite sure. Perhaps if I'm not answering the question completely, the person could let us know who wrote the question, specifically what they were thinking about, if that's not answering it completely.
I guess we can connect with that individual and follow up with you after the webinar. Are there any other questions from the audience?
There's something else in the chat box here from Laura Lincoln. Just wanted to share that while being bedside RN, I have been able to pursue and achieve my BSN and MSN and national certification. Now that I am in a nursing leadership position, I am pursuing my DNP, always advocating for staff at the bedside level to pursue BSNs.
No, thank you, though.
Yeah, thank you for sharing.
There's another question here. Does Geisinger include career coaching in their mentorship program for staff? You are not sure which school to attend or what type of MSN to enter.
Hi, this is Angelo. We absolutely do, and it is part of our one-to-one conversations, both during our leadership rounds, and then on an ongoing basis during annual performance evaluation. We also provide ad hoc coaching and mentorship. So as an example, anyone can schedule time with myself, Sue, any of the other leaders in the organization to seek guidance in an area they're particularly interested in. I'll share a really brief story. We were recruiting for an ED director in one of our hospitals, and she came to us. This was one of our institutions that was recently required, without a BSN, was later in her career and came under the understanding that she was not interested in going back to school, but had a great reputation as a leader. Within 6 months of being in the organization, she said the culture drove her to want to return, and she ended up enrolling in a BSN program. And so I tell you that to illustrate the importance of the coaching and mentorship model combined with culture. There are many force mechanisms we could use to force people to go back, but we believe it's far more important to use other methods.
And Angela, there's a second part of that question. Pamela asked, who does that? Is that part of the nursing professional development department rather than A&M?
It is part of, we believe it's part of everyone's responsibility, including our staff nurses who have taken the leap to go back. And certainly our professional development department is responsible for that, our leaders and our staff.
Hi, can anybody hear me?
We can hear you.
Oh, great. I typed in, but I didn't get it read. My name is Karen Goldschmidt from Drexel University, and I just wanted to say thank you so much for this presentation, and I think it's long overdue. I just want to tell you a little bit about, we have been working at Drexel with Delaware County Community College for the past 4 years, and we have what we call a concurrent enrollment. It's been very successful, and what we've been doing is for when the nurses are, students are in the associate degree, just in the associate degree program part, it seems like there's a big backlog, if you will, of students who can't get into nursing programs because of the nursing faculty shortage. So once they get in, what we're doing is we're allowing them to take courses at the university, and we are pulling them through so that they only have 2 terms when they're finished the associate degree to take to finish their BSN. So it's nice because what we're seeing is that there's they can go out, they are saying they're enrolled in the bachelor's program and that they can finish. We're on the term system, they can finish by March. So gainful employment is increasing. So one of the issues we've had is financial aid, and I've approached probably 10 community colleges in our area, at Philadelphia and all around the area. The community college right now is taking on the financial aid, and it's working really well. But it seems like the community college is very hesitant to take on the financial aid. So the person, financial aid person at DCCC is willing to tell and talk to anybody who is interested in this. It's very easy to do. So if you're interested, you can contact me at Drexel University. I am on the RN to BSN homepage, and it's Karen Goldschmidt. Thank you.
Great, thank you for sharing that. So I'll just begin to wrap up our webinar. For any follow-up questions that did not have the opportunity to be addressed during the session, please connect with us. You can reach me at my email provided here, and I will direct your questions appropriately. We'd love to have you join our networks. You can stay in the loop with our work by visiting our website, signing up for our listservs, and following us on social media. And once again, I'd like to thank all of our speakers for your insight and thorough presentations. I'd also like to thank our planning team, Allison McIntosh, Robin Wagner, and Elizabeth Menscher. And thank you to Sarah Hexum, the Executive Director of the Action Coalition, and Marion Tuff, the Executive Director of PONAL, for your leadership. The link for this webinar will be posted soon, and stay tuned for part 3 of the Future of Nursing series. Thank you.